Hey all, it's Dr. John and welcome to our course on body composition. This is a course I have been wanting to put together for a long time because it addresses the single biggest blind spot I see in our industry right now. Here's the problem. We have incredibly talented injectors and wellness providers out there doing beautiful work, but they are building on a foundation they have actually never looked at. They are treating the face without understanding the body. They are running wellness protocols without knowing whether the patient's biology can even receive those signals. And then they are wondering why some patients get incredible results and others just do not. And that is what this course is about. We are going to connect the dots between what is happening inside your patient's body and what is showing up on their face, their skin, and their treatment outcomes. And here is what you are going to walk away with. First, I'm going to teach you the tools: DEXA scans, BIA devices, and clinical measurements you can do with the tape measure. Then we're going to take that data and look at the face. You'll learn how body composition affects fat pads, why some patients look puffy after filler, and what is really happening with GLP-1 medications. We will also cover the metabolic engine, hormones, blood sugar, and stress. And finally, we'll talk about how to actually have these conversations without making it awkward for your patients and how to fit all of this into your daily workflow. By the end, you're not going to look at patients the same way ever again. All right, let me start by acknowledging something most of us in healthcare have known for a long time, but rarely say out loud. BMI is broken. It is a fine population health metric, but for the individual patient sitting in your chair, it just does not cut the mustard. Let me paint you a picture. A patient walks in, she's 5'6", 135 pounds, her BMI is a normal 22. But when we measure her body composition, 35% of the body is fat tissue and her muscle mass, well, it's well below where it should be. In the literature, we call this normal weight obesity. In practical terms, this is the skinny fat patient. She looks healthy on the outside, but inside she has very little metabolic muscle and she is carrying fat that is creating a constant low-grade state of inflammation. So why should you care? Because that inflammatory fire is working against every single thing you do for her. Think of it this way. Imagine you are a painter hired to do a beautiful mural on the side of a building. You have the best brushes, the best paint, and the talent to do something incredible. But the wall's crumbling. There's rust, water damage, cracks in the foundation. You can still paint that mural and it might look good for a while, but the wall's going to win. That is what happens when you inject filler or deliver a wellness protocol to patients whose biology is working against them. The metabolic wall is compromised and their internal environment is degrading your results. For those of you doing the wellness side, doing IVs and peptide protocols, this data is just as critical. You cannot expect a peptide to signal effectively in a body swimming in inflammation. If you are prescribing growth hormone secretologs in a patient with high visceral fat, you're trying to have a conversation in the middle of a hurricane. Their cellular receptors are downregulated by the very signals their own fat tissue is producing. So when you start measuring body composition, you stop guessing. You move from, I think this will work, to, I know what this patient's biology needs. It changes the conversation from reactive to proactive. Instead of waiting for a patient to come back disappointed, you're telling them on the front end, hey, this is what your data shows. Here's what it means for your results. And here's how we are going to optimize everything so you get the absolute best outcome, right? We shift the conversation a little bit. Our healthcare system is getting great at treating sick people. It is not great at helping people stay well or look their best. That is where you're going to come in. You're in a position to help people get well so they can look their best. And that changes everything you know about practice. Now I'm going to hand you all the actual tools to measure body composition. And there's a spectrum available for you, from the gold standard all the way down to tape measure. But having some data is always better than having no data. So the gold standard in body composition measurement is the DEXA scan, dual energy X-ray absorptiometry. You will not have one of those in your office. This is always a referral. You partner with a local imaging center or a longevity clinic in your area, and most of these places are actively looking for referral partnerships because it drives traffic to them. It's a genuine win-win. So when you send a patient for a scan, you frame it as a prescription, not a suggestion. You say, hey, I want to get a baseline body composition scan so I can give you the best possible treatment plan. It takes about 6 minutes. You keep your clothes on, and it gives us a roadmap to your internal health. And what you're doing is you're taking that salesy feel completely out of the equation. Now, what I love about DEXA is it gives you a 3-compartment module. Imagine a jar full of 3 things: rocks, water, and oil. A bathroom scale just tells you how heavy the jar is. A DEXA opens the jar and separates out everything: bone, mineral content, lean soft tissue, and fat mass. Okay? That lean soft tissue is your patient's metabolic engine. Skeletal muscle, water, organs. High lean mass correlates with better insulin sensitivity, better wound healing, and better treatment outcomes. But it is not just about how much fat your patient has, it's about where that fat is living. So when a DEXA report hits your desk, I want you to focus on 3 markers. First, the Appendicular Lean Mass Index, or ALMI. This measures the muscle in your patient's arms and legs. If it is low, your patient is losing the structural framework from the inside out. They do not have the protein stores or metabolic scaffolding to support the collagen that you might be trying to build with like an aesthetic treatment. A low ALMI patient is going to be a poor responder to treatments. They're not going to heal as well. Second, visceral adipose tissue, or VAT. Subcutaneous fat is mostly just storage, like boxes sitting on a shelf. But visceral fat wraps around the organs and acts like a factory pumping out inflammatory chemicals around the clock. When you see VAT mass over about 1 pound on that report, that patient is carrying a low-grade inflammatory fire that affects how long their filler lasts, how well they heal, and how their skin responds to every treatment you do. It's also likely a culprit to why they might be insulin resistant, or why they might be struggling to sleep at night, or why their cortisol's through the roof, right? Constant secretion of inflammation stresses you out, increases cortisol. It's this vicious, circle, just building and building and building until it becomes out of control. Third, the fat mass index. This tells you how much of your patient's weight is actually fat tissue, regardless of muscle or bone. If fat mass index is high and ALMI is low, you're looking at a patient who needs functional support before they need 3 syringes of volume. Okay? So let me bring this to life. Let's use an imaginary patient. Sarah, she's 42, she wants mid-face volumization. She's lost some fullness in her cheeks and does not like how tired she looks. She is 5'5", 138 pounds, BMI is 23, everything looks normal. Her PCP has probably never once mentioned her weight. But her DEXA scan shows a low ALMI, a fat mass index putting her at 36% body fat, and a VAT at 650 grams. That's well over our threshold. Sarah is the textbook skinny fat patient. She looks fine with clothes on, but metabolically, she has a low-grade fire burning. Very little muscle to support tissue structure, and her body is not set up to make the most of the treatment she's asking for. Does that mean you turn her away? No, absolutely not. But you have an honest conversation. Sarah, I want to give you an incredible result. But, your scan is showing me that your body's internal support system needs some attention. Your muscle mass is a bit low, and there's some internal inflammation that is going to work against our results. So here's what I recommend. Let's start conservative today. And let's also talk about increasing your protein intake and getting some resistance training going. As your engine gets stronger, your results are going to get better and they are going to last longer. So you see what just happened? You did not fat shame her. You did not put her on a diet. You used objective data to position yourself as a clinician who cares enough to look deeper. You just differentiated yourself from every provider ever who would have loaded 3 syringes without even looking under the hood. Now, not every patient is going to get a DEXA. Do I put DEXA scans on all my patients? Absolutely not. If they say no, you have a BIA or a medical grade bioelectrical impedance device in your office. And I'm not talking about a $20 Amazon scale. I'm talking about a medical grade multi-frequency device. These sends out multiple frequencies of current through their body and measure how it travels through different tissues. Muscle conducts electricity well. Fat does not. A BIA gives you a phase angle, which measures cellular membrane integrity. Think of a healthy cell like a fully inflated balloon. Good tension, good structure. A sick cell, deflated balloon, floppy, leaky, not functioning well. Low phase angle is a huge red flag for inflammation. It also gives you an android to gynoid ratio, telling you where fat is stored, and it gives you lean body mass estimates by body segment. So if you do not even have a BIA yet, go old school. Waist to height ratio is far better predictor of metabolic risk than BMI. If there is a waist circumference is more than half their height, you can bet they have elevated visceral fat. The research on this is rock solid. You can also look at upper mid-arm circumference to screen for muscle wasting. right? The point is this: gold standard is DEXA as a referral. Work out a deal with your local imaging center. Say, hey, if I send you patients, what's the cash deal? You'll be surprised at how inexpensive it can be. Your daily workhorse, this is what you have in your office, is your BIA. And keep it in your office, carry it with you if you're a mobile clinic. And at the absolute minimum, get a tape measure out. Measure that waist, measure the upper arm. Take baseline treatments, especially if you're going to put somebody on a GLP-1. If you're noticing their arms are shrinking on a GLP-1, then they're not building body mass. No matter where your practice is, you have the tools to start doing this today. And whenever you measure, chart it. That data is going to become one of the most valuable things in your patient's record. All right, we've looked at the body. Now we bring it above the neck and then go deeper into the metabolic forces driving everything. Because the face is not an island. It is the direct reflection of your patient's metabolic health. So let's do a quick refresher on facial aging. You have deep fat pads that provide structural support, and you have superficial fat pads that provide contour. Holding it all together, you have retaining ligaments. Think of these like suspension cables on a bridge. In a young, healthy patient, those cables are nice and tight and the structure is sound. But as we age, our systemic lean mass drops and those cables stretch and the tissue starts to droop and some of the cables break. And that is how you get these heavy like lines and nasolabial folds and marionette lines and the jowl, because those cables are breaking. And that gives you that tired look. Now, here's where your body composition knowledge becomes your superpower. When a patient has high visceral fat, their facial tissues are actually heavier than they should be. And gravity's always going to win. It's going to pull everything down. Chronic inflammation causes the tissues to hold on to water. Those inflammatory cytokines increase vascular permeability. Fluid leaks into interstitial spaces, and all of that extra weight is pulling down on those suspension cables every single day. At the same time, things like TNF alpha is suppressing collagen production. So the ligaments are under more load with less repair happening. It's like a double whammy, it's a double hit. Now flip to the other side, sarcopenia, the age-related loss of skeletal muscle mass. This is the silent driver of the aged look. The masseter, the temporalis, these are skeletal muscles that respond to the same signals as the muscles in your arms and legs. When they waste, you lose the lateral tension that holds the face wide and lifted. You see it as a hollow temple, a soft jawline, a face that seems to be narrowing inward. If you try to treat a sarcopenic patient with filler alone, you end up replacing muscle with volume. Filler does not contract. It does not provide tension. It just sits there. And that is exactly how you get that overfilled look. So be very cautious with somebody that's sarcopenic, that you want them to look natural, not fake. Now let me talk to you something about I call the filler paradox, because this might be the most important clinical concept in this entire course. Your hyaluronic acid fillers attract water. This is literally their mechanism. In a healthy, non-inflamed face, that is beautiful. It plumps, it lifts, it creates that gorgeous, dewy look. But what happens when you inject that same hydrophilic substance into a face that is already inflamed and holding on to water? You're not beautifying them at this point. You're adding weight to a waterlogged system. Now, I remember when I went to Italy, I ate all that wonderful food, fresh ingredients, olive oil, the whole experience. I mean, it was just wonderful. My skin looked great. I felt amazing. I came back here, ate our American processed stuff for a couple days, and within 48 hours, my face looked like a bloated mess. And I'm not exaggerating. This is what systemic inflammation does to the face. You eat that crappy food, you get the leaky gut, your inflammation goes through the roof, and you puff up. Like, have you ever heard somebody say, oh, I'm retaining water? You're inflamed. That's why you're retaining water. So when a patient with high VAT and systemic inflammation gets a syringe of HA filler, that product attracts even more water in tissue that's already swollen. 2 weeks later, they look boggy and puffy, they look older, not younger. And you are confused because your technique was perfect. Your technique was fine. The biology was not. That was the problem. The wall was crumbling down, and you painted a beautiful mural on it anyway. This is why when you see that inflammatory profile, you know you have to be conservative with things like hyaluronic acid volumes or consider a biostimulator instead, right? Now, the topic on everyone's mind, right, as we get into this, GLP-1 medications. When prescribed to the right patient who needs them, GLP-1s are an incredibly powerful tool. But you need to understand what happens to the face during rapid weight loss. Those deep fat pads deflate faster than the skin can adapt. That is how we term the coined Ozempic face. But here's the piece most people miss. The question is not just that are they losing weight, it's what kind of weight are they losing? So let's talk about a fictional patient and we'll name her Diane. She's 54. She lost 45 pounds on GLP-1 over 8 months. Her primary care doctor is thrilled. Her A1C is down. But Diane comes to you and says, I've lost all this weight and everyone tells me I look sick. My face looks hollow. And when you compare her DEXA scans, if she did her DEXA scans, you see her fat mass is down, which is great. But boy, so is her ALMI. She lost meaningful muscle along with the fat because her protein intake was barely 50 grams a day on a restricted diet. Her face is collapsing from two directions: fat deflation on the top of the muscle and the muscle that's wasting. And the residual visceral fat is still driving some inflammation. So you tell her the truth. Diane, congratulations on your weight loss. Your metabolic numbers are looking much better. But your DEXA scan shows that you've lost some muscle along with the fat, and that muscle is what gave you your face's structure. Before I start adding volume, I want you to work on rebuilding that foundation. Let's get you to 100 grams of protein a day and resistance training 3 to 4 times a week. And I will be conservative with filler today. As you know, but as your engine stabilizes, your face is going to hold this work much better. Diane's going to appreciate that conversation. You didn't turn her away, you treated her, but you also gave her a plan that addresses the root cause. And you are probably the only person in her healthcare team who's actually watching the muscle to fat ratio. What a valuable role that you have. It's incredibly valuable. All right, let's go a little deeper into the chemistry that makes the whole system run. Estrogen dominance. Visceral fat contains aromatase, an enzyme that converts androgens into estrogen. Excess body fat means excess estrogen production, which drives fluid retention. That chronically puffy patient who looks swollen no matter what, often an estrogen to progesterone imbalance driven by body composition. Add HA filler into that environment and it looks boggy every time. Glycation. When blood sugar spikes, sugar molecules attach to proteins, creating advanced glycation end products, or AGEs. I tell patients that glycation literally caramelizes your collagen. Those flexible fibers become stiff, brittle, and yellow. You can stimulate all the new collagen you want, but if blood sugar is chronically elevated, the body destroys it as fast as you build it. You are filling a bucket with a hole in the bottom. Here's a case study for you. When I first got into the industry, I had a woman come in. I didn't know it, but she had diabetes, undiagnosed diabetes. I didn't test it. I didn't check for it. She was definitely a little overweight, a little puffy, and her skin just looked awful. And I go, let's get you on a microneedling course. I did microneedling on her every month for 9 months. After 9 months, I looked at her before and afters. You couldn't tell I had done a dang thing. And I was perplexed. I'm like, what is going on with this patient? And she was frustrated. She spent all this time and money getting microneedling and really didn't look that much better from it. And then I thought, maybe there's something going on here. And I sent her to her primary care provider who'd ran labs, and sure enough, she had an A1C of like 8.2 or something like that. She was diabetic. All of that collagen that we were making was getting glycated. The sugars were making it brittle. It wasn't building the structure I was hoping it would build. Now, if I had done a good body analysis on her, I would have known that from the beginning, and I would have got her on a weight loss program and a muscle mass regimen, right? But I didn't because I didn't know what I didn't know. And so that's just one example of what we're talking about. Now let's shift gears a little bit and talk about another problem child, and that problem child is cortisol. Here's the thing about cortisol. Chronic stress drives cortisol, which does two things. It tells the body to store fat in the midsection, increasing that fat mass. And it is catabolic. It thins the dermis, slows healing, and weakens collagen. A high-stress patient bruises more, heals slower, and gets less predictable results. So cortisol is a big problem. If somebody looks stressed and feels stressed, signs of high cortisol could be like hair shedding. You can ask them, hey, how's life going? If they're like, oh my gosh, I'm dealing with a divorce, or I'm dealing with a job change, or something like that. Think that they might have elevated cortisol levels. Do I test for cortisol? No. But usually just by asking the questions, a few simple questions to your patients, you can get to the bottom if they're stressed out or not. Sleep's a great prediction of high cortisol. Hey, how much sleep are you getting a night? If it's less than 7 hours, they're stressed out. Their cortisol levels are going to be increased and they're not going to get optimal results. And have that conversation with them. Hey, I'm going to get you on a microneedling treatment, but you might be at an elevated level of cortisol based off your poor sleep and that you lost your job. I'm happy to start doing it now, but maybe we should get the stress under control, lower the cortisol so you heal better. Things like that. Patients really appreciate that stuff. Okay, now here's the good news. Muscle is medicine. When patients build lean mass resistance training, muscles secrete myokines that improve mitochondrial function in the skin. This is what gives skin its inner glow. More muscle often means better insulin sensitivity, which means less glycation, which means better collagen. It's all one connected system. The visceral fat drives estrogen and inflammation. The inflammation drives glycation and collagen breakdown. The cortisol drives more visceral fat storage. And the lack of muscle takes away the one thing that could fix it all. When you improve one piece, the others start to follow. Help a patient build muscle and their insulin sensitivity improves. Better insulin sensitivity means less glycation. Less glycation means healthier collagen. Healthier collagen means your treatments last and look better. They last longer and they look better. It's an awesome cycle if you do it the right way. And you are the provider who started it all. I know what some of you are thinking. You don't want to be the provider who makes a patient feel judged. But if you see a metabolic fire burning in your patient and you stay silent, are you really being their advocate? The key shift is this: move from subjective judgment to objective data. You're not saying your weight is a concern. We're saying your composition data shows us an opportunity. This is why having a BIA or a DEXA is a game changer. It takes the you versus me out of the equation and puts the data in the center. I call this the aesthetic entry. You lead with their goal, not their body. If a patient wants mid-face volume, you say, I want to get you the most natural lift possible. But to do that, I want to make sure your skin's underlying support is healthy. Would you be open to looking at some composition markers to see how they might be affecting your results? And then you put them on the BIA and you get that in-office quick data and that you can use for to say, hey, based off this, we might want to do a DEXA, right? You led with their goal. You connected the data to their outcome and you asked for permission. Would you be open to is everything. It respects their autonomy and invites them into the process instead of lecturing. All right, now vocabulary. In this practice, we do not talk about dieting. We talk about fueling for collagen. We do not talk about exercise. We talk about muscle preservation for structural support. We don't say, you need to lose weight. We say, let's optimize your composition so your aesthetic investment pays off. When data shows high visceral fat, you say, your scan shows some internal inflammation that acts like a metabolic noise. It might break down our work faster. My goal is to cool that fire so your investment lasts. All right, so let me show you how this sounds in practice. Fictional patient Rachel, she's 47. She comes in for her regular talks. And you notice after the last few visits that her skin quality has really been declining. She's bruising more easily. Her last round of talks, was a few weeks less than usual. And, because you have a BIA in your office, you see from her last BIA that we have a dropping phase angle and a rising android to gynoid ratio. After her treatment, you say, Rachel, your talks looks great, but I want to bring something up because I always want to be straight with you. Over the last few visits, your treatments have not been holding quite as long as we are used to seeing. When I looked at your body composition data, it gave me some insight into what might be happening. So you pull up her BIA report. See this number here? This is your phase angle. It tells me how healthy your cells are literally at the membrane level. Yours has come down a bit, which tells me your body might be in a more inflammatory state than it was 6 months ago. Now, none of this is alarming, but it explains the shift. So here's what I would love to do. I'd love to see you increase your protein to around 100 grams a day and add some resisting training, even 2 to 3 days a week. If we can move these numbers in the right direction, I think you're going to be seeing these treatments start lasting the way they used to. Would you be open to trying a couple of months and then we can rescan? Now, what did you do? There's no judgment in that. Rachel doesn't feel judged. She feels informed. She feels like she finally has a provider who actually understands what's happening and has a plan. And that is one level of trust no one else is building it for her. And here's the business truth. Doing what is right for the patient will always have economic advantages for you. Rachel is not leaving, for a discount injector because no one else is having this conversation. And we have a full course on consultation protocol that goes deeper into the mechanics of running a thorough consultation. Definitely check that out if you want more tools for those conversations. Now, how do you fit this into a 30-minute slot? I call it the metabolic first approach. Before you walk into the room, your MA or yourself should have that patient's BIA report on the screen. It takes 30 seconds at intake. You walk in, greet them, and before you look at the face, you look at the foundation. It's going to take you 90 seconds to scan the ALMI, their visceral fat indicator, their phase angle, and then you move into the consultation. For DEXA referrals, have referral cards at the front desk that have your imaging partner's contact information on it. Frame it as a prescription. Hey, I want a baseline body composition scan so I can give you the best treatment plan. For your GLP-1 patients, specifically a baseline DEXA and follow-ups every 3 to 6 months should be standard. You need to know if they are losing fat or losing the muscle that supports the face. If you have questions about the ordering process in your state, check with your medical director and hop into our compliance forum if you want to start doing those DEXA scans. For documentation, create a consistent place in your notes for metabolic markers. When a patient comes back saying, my filler didn't last, you can open that chart and say, well, when we started, your visceral fat was elevated and your lean muscle was low. We discussed that this environment might lead to faster product degradation. You're not defensive. You're a clinician who predicted a result based on the data. And use clinical language. Instead of patient is overweight, right? Patient presents with elevated VAT mass of 750 grams, suggesting a pro-inflammatory systemic environment that may impact treatment longevity, right? Patient canceled on protein optimization resistant training. And that chart note tells a clinical story. It protects you to some degree. It protects your medical director. But more importantly, it builds trust with the patient. One final thought. Not every patient needs a full metabolic deep dive on day one. Some patients want their angry 11s and want to get back to their day. It's perfectly fine. You're still providing a thorough elite experience and you're still observing, still watching, for those red flags. But you're not forcing a metabolic conversation on someone who just wants a quick touch up. That's not good clinical practice. That's just annoying. The key is clinical intuition, the red flags that should trigger a deeper look. Skin quality deteriorating between visits, treatments continually underperforming, patients on GLP-1 protocols, or patients who look puffier and more fatigued in their last visit. In those moments, pause and say, you know what, I think you should look a little deeper. Would you be open for getting a scan? For everyone else, you're providing excellent care, plant seeds, and stay ready. Respect their autonomy. Be available when they are ready. And when they're ready, they're going to come to you because you already showed them that you have the knowledge to help. All right, that is the course. You walked in knowing how to do great work. Now you have the ability to see the whole person. You understand what a DEXA scan tells you and which markers matter. You can use a BIA or a tape measure to get your meaningful data, and you can read the metabolic story underneath the face. You know how hormones, sugar, stress, they drive the aging process. You know how to communicate all of this with empathy and data. And you know how to document it and build a practice based on long-term patient transformation. Our healthcare system in the US is great at treating sick people. It's awful at helping people stay well. That is where you're going to come in. You're in a bountiful industry that is growing every single day, and the providers who win are the ones who treat the whole person. Your education never ends. You do not know what you do not know, but the application of what you have learned here will set you apart from everyone else. Now you have the tools, you have the science. Go seize the day and make it your own.